Hello everyone, this is Pallavi Mudgal and welcome to my YouTube channel. So today's topic is Achalasia cardia. Now before starting with the video, please subscribe and press the bell icon and like if you like the video, okay? Achalasia cardia is defined as it is the failure of relaxation of cardia, that is the G junction, which is due to disorganized esophageal peristalsis as a result of failure of integration of parasympathetic impulses causing a functional obstruction. As we can see here in the diagram, there is failure of relaxation of the LES, due to which there is dilatation of the proximal part of esophagus and collection of food in this part. Now next is types of achalasia. There are 5 types, in which number 1 is primary achalasia, in which there is loss of ganglion cells. Number 2 is secondary achalasia, which is secondary to Chagas disease. Another one is vigorous achalasia. The one which is rapidly progressive is vigorous achalasia. Another one is pseudo achalasia. It can be seen in any kind of malignancy. It is not true achalasia. It is due to cancer. Another is type A syndrome, which is also known as Algrove syndrome, in which you have to remember 3A, that is alacremia, achalasia, and ACTH resistance, adrenaline insufficiency. Next is etiology. In this, it is always due to absence or less number of ganglions in the myenteric plexus. Can be due to stress or vitamin B1 deficiency. It can be secondary to Chagas disease, which is caused by Trypanosoma cruzi and commonly called as sleeping sickness. Another one is diffuse esophageal spasm, in which we can see corkscrew esophagus. You can see in the image there is corkscrew appearance of the esophagus. There is like in between spasm in the esophagus. Yeah. So next is, most commonly it is idiopathic, and there is degeneration of the orobax myenteric plexus as well along the entire length. And we can see pencil shaped narrowing of the cardia, the OG junction, where enormous dilatation of the proximal esophagus, and it contains foul smelling fluid. Also, achalasia cardia is a precancerous condition which has 7 times chances of getting squamous cell carcinoma. Now let's move on to the pathogenesis. What do we see in this? There is thickening of the circular muscle fibers in the distal esophagus. There is myenteric inflammation, depletion of the ganglion cells, neural fibrosis, reduced nitric oxides, and VIPs. Now next is, there is absence of peristalsis, there is raised LES pressure, failure of relaxation with functional obstruction of the OG junction. And dilatation of the proximal esophagus is there with atony. There is no tone left in the esophagus. Now, what are the clinical features? It is commonly seen in female between 20 to 40 years of age group, and the incidence is 6 per lakh. 6 people per lakh population. They experience chest pain. There is progressive dysphagia, that is difficulty in eating something or swallowing, which is more for liquid than for solid food. There is regurgitation because the food is not going inside, and the patient feels comfortable when he is walking while eating, or there is chin thrusting, there is neck and shoulder extension, and due to Valsalva maneuver, because all these things aid in emptying of the food. Okay. There can be heartburn, which is 50% common, malnutrition, and general ill health. There is lung abscess formation, odynophagia, weight loss. There is chest infection, recurrent chest infection with nocturnal cough and laryngospasm. And also there is esophageal candidiasis and halitosis due to presence of stale food in the esophagus. Now very important is this triad of the symptoms, which you have to remember: dysphagia, weight loss, and regurgitation. All these 3 things go hand in hand, because there is dysphagia, the person will not eat, he'll be having weight loss, and whatever he's eating, that is not going down, that is not going down through the sphincter, so it is being collected in the esophagus. It can cause regurgitation. Okay. So what are the investigations we do? First of all, we do the barium swallow, in which we see the gradual tapering of the esophagus, which where it is compared with the bird's beak. We can see here the appearance is just like a bird's beak. You can compare it here with the picture. And also in the proximal region, there is dilatation of the esophagus, which can be compared with the cucumber. And that's why it is having a cucumber appearance, also known as megaesophagus. In chest x-ray, we see the patches of pneumonia due to aspiration pneumonia. What is the gold standard? It is esophageal manometry, and the following findings are there in it. That is ineffective contractions in the body of esophagus and inability of LES to relax. Also, esophagoscopy is done to rule out carcinoma, esophagus, and to confirm the diagnosis. We can also do biopsy of the mucosa at the LES. So the treatment of Achalasia cardia is, we do the following surgeries, that is modified Heller's cardiomyotomy with Topes or Dors's fundoplication. The GERD is the common complication in this. It can be done with open abdominal or thoracic approach, laparoscopic approach, which is considered ideal, or robotic assisted laparoscopic approach. Also, we can do resection of the OG junction or transhiatal total esophagectomy is done in severe cases like megaesophagus and metaplasia. But the latest treatment we prefer is POEM, that is per oral endoscopic myotomy. It is forcible dilatation. It is done with the plumber's pneumatic dilatation or Negus hydrostatic balloon dilatation. The common complication again in this is GERD, which is due to overdistension. Sometimes we also use drugs, that is botulinum toxin. It is used, but there are very high chances of recurrence in this. We can use nitroglycerin and nifedipine as well, but it is not of much use. Okay, so that's all for Achalasia cardia. If you have any doubts, please comment in the comment section below. And thank you for listening. Do subscribe and like the video. Bye bye. See you in my next video.